Thanks so much for joining us today to walk us through two pretty complex policy proposals. One of them I wanted to start with is actually an executive order. It's already in place, but you're still working out the details as the director of the Department of Insurance. Can you tell me what the executive order actually does?
Well, first and foremost, kudos to Governor Otter and Lieutenant Governor Little for continuing to fight for Idaho families and try and find ways to have more affordable coverage. That's what the executive order is about. It's about giving me the authority and the responsibility to be creative and try and develop products that we can sell to Idaho families that are significantly lower priced so that they're not forced out of coverage.
And so tell me exactly what that means. It means that there are no longer mandates in what insurance companies have to provide?
We have many provisions in Idaho law already, many of them that were in place before the ACA. We like to think in many ways we solved some of the problems the ACA was attempting to solve without driving rates up. We like to think that we've managed those better. So we fall back to our own code, our own rules, our own provisions, and so we use those to tell carriers what types of products they can offer and what those products have to have in it. Now, we're also realists, and we know that there are certain things that even though it's not required in Idaho law, the federal law requires that it be covered. And so we're instituting most of those and trying to walk a fine line between what would be acceptable and what would be unacceptable to the federal government. We believe that when the President and Congress passed and repealed the individual mandate, that meant consumers didn't have to buy ACA compliant plans. That means they can buy something else. So what are their choices? Well, in today's market, without the executive order, their choices are to go without coverage and pay a penalty, or when the law kicks in, they'll avoid paying a penalty, or they buy a short-term medical plan that's 10 months in length but has a 12-month pre-existing condition clause, and they hop from company to company with that 10-month plan, never having a pre-existing condition covered. And by the way, the ACA allows that to happen. Or they've stayed on their grandfathered or their grandmothered plan, the transitional plans, which have a pre-existing condition clause. Or they're going to a Christian ministry, faith-based program, which also has a pre-existing condition period. And those have become the choices that families, Idaho families, who don't get a subsidy are being forced to take on.
And so you said something that stands out to me. We believe this allows Idaho to take this action.
Right.
Are you positive that this allows Idaho to take this action?
Well, we'll see, won't we? I mean, in reality, I had a meeting, phone conversation with our federal partners, and they're asking a lot of questions, and we're trying to provide them adequate answers. And there will be several steps along the way. We'll issue the guidance, then we'll wait and see if a carrier files products. If no carriers file products, we're stuck. Then if a carrier files products, the federal government may say, well, we want to see these products. And we'll be happy to talk with them about it. Then we have to decide if we're going to approve those products. And once we approve the product, then that may be another time when the federal government looks at it and says, okay, did the department act responsibly in approving? Then if we've made it through those bridges, then the consumers would hopefully be able to buy those products. And once the first person buys a product, then that's really the measurement. I think based on our judgment, based on what we've seen, based on talking to the carriers and the actuarial computations of these items that we're looking at, which gets all complicated, I think you'll see products that are significantly lower in price, that are still better products than anything in the marketplace today, with the exception of the ACA plans. So they're not going to be as good as the ACA plans, and they're not intended to compete with the ACA plans. In fact, we've got provisions in there to keep that from happening, to keep the cherry picking from happening, to keep them in the same pool so that these products will help lower the rates or keep rates down for those who stay in the ACA products. So we see it as really a win-win for Idaho consumers who are buying insurance on the individual market.
Now, I'm curious if you see the problem that's being solved here the same way that others are seeing the problem. Do we even agree on what the problem is in the first place?
Well, you know, when you talk about healthcare and the problem, it's a huge conversation. It isn't specific to insurance plans or even to Medicaid. It's a problem that crosses all socioeconomic boundaries. It's about access. In rural Idaho, we have real significant access issues in terms of healthcare, just keeping doctors in some of those areas. But with regard to the insurance, and this is what the legislature will need to walk through and try to understand as we go forward this session, is making certain that these choices are going to be valid for a lot of Idahoans. I know that our caucus does have a concern about the elimination of mandated pregnancy benefits and the kind of assumption that might only apply to women. Granted, women may be the people carrying the babies, but there's equal participation in the conception of those babies, and you know, we've got some concerns about whether this might not be discriminatory or not. But it's early on, and we have a lot to hear and to talk about and to understand, so we'll work our way through those concerns.
And I was hoping you could address those concerns, because as a young woman who was sitting through the unveiling of the executive order, you know, I heard the governor make a joke that, you know, he wouldn't have to pay for mandated maternity coverage. The issue with that, though, is it makes my maternity coverage more affordable. So how do you balance that, and will maternity coverage be mandated?
You know, I think the fundamental question that I think you have to ask, first of all, is, do we have to require that every plan have every single benefit and that every consumer of those plans buy every benefit? Do we require that everybody has to buy a Dodge truck? Or maybe they want a Chevy, or maybe they want some other version. I think this is a compassionate approach that allows people to choose the plan that best fits them. It's almost, it feels like, and I know my colleagues here are compassionate people, but it feels like we're ready to walk past a starving child with a loaf of bread and unwilling to give it to them because it doesn't have all the ingredients in it. And that's, I think that's wrong for society. That's, I think, fundamentally wrong in the philosophy. Now, to set people's minds at ease, maternity is a requirement of the 10 essential health benefits and is included in our guidance. The question that may come up is, will maternity be required to be covered exactly the same way as it's covered under the ACA? Remember that in today's market, people can change plans. You can choose. So if you found out, for example, today, if you're a young woman today and you found out that you were pregnant and you were not on a plan, what would you do? Well, you can't go to any of the other plans I talked about and have any sort of coverage. Under our proposal, under the executive order, you might be able to go buy a plan, and yet may have some differences on how it would treat maternity. And by the way, you can't be denied. So come next open enrollment, you may say, and by the way, maybe that open enrollment occurs before the baby's born. You might say, you know what, I've had this plan for the last 8 months. I'm going to jump over and be on an ACA plan for the delivery of the child. So you will have that. You will have the choices to be able to choose the plan that best fits you at that time.
So a Chevy is available to everybody, but I need a minivan for all my kids. Will I be able to afford that minivan?
That's what we really hope. I'll tell you stories. Family in Oakley. Fred may know them. I don't know. I won't say their name. 6 kids. They went from buying a gold plan at $900 a month. In 2015. In 2016, they went to $1,200 a month and went to a silver plan. Then they changed the silver plan in 2017 and went to $1,300 and something a month. And in 2018, the rate for them is over $2,000, $2,160. So what's their choice? They either choose to go without coverage under today's market, or they go to a faith-based Christian ministry sharing plan. and then find out some of the items that they think are important aren't covered there. So that we're trying to find a solution for those people. The school teacher who's the district pays for the teacher but not for the spouse and kids and doesn't qualify for a subsidy and can't utilize that, we're trying to find a plan that meets their needs. Will it be a perfect plan? No, but it'll be better than what's in the marketplace today.
Representative Wood, I wanted to get your perspective.
Well, I think that most of us would agree on a couple of the problems. One is the high cost. The issue that you have with ACA non-qualified plans is what will that do to the ACA qualified plans? Choice is good. These products will be very good for a lot of people, particularly the young, the healthy, the people who don't smoke, et cetera, or have significant issues with lifestyle. But you have to be careful. If you're between the ages of 55 and 65, and at 60 when the big death spike occurs in humans, you're going to want an ACA plan. You're not going to want partial coverage. If you're 25 years old and you're good and healthy, you bet this is a good choice. But if you pull all of those people out of the large ACA pool, what does that do to the ACA plans? So I applaud the governor and I applaud the director for thinking outside the box. I don't think this is a bad thing at all. I think it will be a good thing, but I think people are going to have to be very careful. People are going to have to become very knowledgeable in their own health care, far more than they are today, which is a good thing. Everyone should be. But a lot of it is we'll have to see, and the details aren't out yet. I think it's premature to judge anything yet, but I like what I see, and I applaud the governor and the director for thinking outside the box for sure.
Representative Wood brings up a great point. One of the problems we have in our marketplace today that's driving rates, that are making rates too expensive, is the market has been bifurcated. The young and the healthy are being pushed out and are being forced out. And every time rates go up, more people are being pushed out. And if we don't do something, even if it doesn't quite work perfectly, if we don't do something, eventually even the unhealthy will be pushed out. Carriers will withdraw from the marketplace because they are losing money. They cannot make it in this marketplace. I did want to catch on a couple points that Representative Wood made that were really good. First of all, it will help the young, but it's also going to help those that are older. I can tell you a story of a 63 and 62-year-old couple in Twin Falls, Idaho, who were paying $1,300 a month for their coverage, can't afford that anymore. So they've decided to go to a short-term medical plan, pay $730 a month for coverage, but that's a plan that has a 12-month pre-X, it's a 10-month plan, and then they'll hop to the next company and have another 10 months with a 12-month pre-X. So in essence, they'll do that till they turn 65 and never have any pre-existing conditions paid for. That's not appropriate and that's not good. So what we've done both in the executive order and you'll see it in our guidance are two features that we think help solve what Representative Wood's talking about. And first, acknowledge that the market is already bifurcated. And so we're trying to bring the healthy back into the market to help hold the rates down on that. First, we require that in order to sell these state-based plans, they have to also be on the exchange. So a company can't come in from out of state and say, I just want to offer the state-based plans. I'm not going to play in the exchange market. So we're requiring that. So that helps avoid the cherry picking, okay? Secondly, we're requiring that they're in the same risk pool. So the ratings will be tied together. So if you pick your company, they come in and say, we need a 15% increase, it's going to be a 15% increase on both types of plans. So they'll be tied together based on state law. There's no requirement in the federal government for it, but based on state law, that will help tie it together. It won't give as much of a discount as maybe some were hoping, but it will still do a great job in lowering rates.
Director, do you anticipate bringing this session, the legislature, any legislation associated with this, or is there any state statutes that need to be changed to implement your vision at this point in time? understanding that you've not completely settled on what that is.
Right. We don't anticipate at this point. Now we're open, and if people have concerns that need to be addressed, we'll certainly look at them. We don't anticipate any legislation. The executive order does also say that I could pursue a waiver, different from the dual waivers, the Idaho Health Care Plan that we've been talking about, but I could pursue a separate waiver. If for some reason before the end of the session we were getting significant pushback from the federal government, then that might be something that we would consider. But
So a waiver from the state government to give you an out if this isn't
I would have to
working.
go to the legislature and say, can I apply to the federal government to do these type of approaches? I don't want to do that unless I have to. That's sort of a last ditch. And frankly, we plan on being pretty stubborn with our federal partners, because we already know, for example, they allow transitionary plans which don't meet all the requirements of the ACA. And by the way, they're not in the law. That's by President Obama's edict that they offer those plans. And so we think there's a precedent to offer that kind of plan just based on what President Obama did.
What is the biggest hurdle for you getting this done?
That's a really good question. I think the biggest hurdle right now is us getting the guidance completed, because every day I hear more and more comments of fear about something not being covered or not being, pre-existing conditions, and a sort of a lack of understanding of how it is in the marketplace today and how people are being forced to have a pre-existing condition today. I mean, if you found out you had cancer today and didn't have coverage, what are your choices? Well, you have the choices we talked about, or you can wait till next open enrollment, which is 11 months away, to get enrolled on a plan. So those things are still there. We're trying to make it easier and better for consumers. And so I think the first hurdle is getting the guidance out there so people won't be afraid or they won't be concerned, and that they can, they're not going to like everything in it. I don't think anything that passes both bodies ever is universally loved. But I think they'll be able to see, is there a marketplace for this? Am I helping Idaho constituents, Idaho families be able to obtain coverage? There will be some. I've had some legislators say to me, look, Dean, there are going to be some folks that will never come back into the marketplace. And that concerns me, because we may, for the first time, have a generation who has decided to operate without insurance. And they're putting their farm at risk, their house at risk, their family viability financially at risk. And so that's a concern. I got to redirect that somehow.
It sounds to me like, Director, that what you're trying to do is we all understand what was going on prior to 2010 with pre-existing conditions, et cetera, et cetera.
Right.
Sounds to me like you're trying to, and I applaud you for this, if in fact that's what you're doing, is to say, we understand now the issues and deficits in the old way that insurance operated. But the Affordable Care Act is also putting up a bunch of barriers with respect to people being able to afford it. So let's see if we can't go back and improve upon the pre-2010 and get it as close as we can and still have significant savings.
I think
Would that be a fair assessment?
Yeah, I think that's a really fair assessment. And we're not going to roll back the clock to all of those. These plans will be better than those plans were. They will address
to hear
issues
that.
better. They will be better than what consumers are being forced to choose between right now.
What I appreciate so much about this conversation is, I think, the acknowledgement that we all have that these are all pieces of a much larger problem.
Right.
And so that in itself is almost progress in the way that healthcare is discussed in the legislature, because for a time it was only addressed in terms of yes or no on Medicaid expansion. And as we've stepped through all of these different experiences with healthcare, we've realized just how many pieces there are. And I think also realized that no one program, either this proposal or the dual waiver that we'll come to in a little while, is going to solve all the problems. They're all a piece of the puzzle. But the fear out there is exacerbated, I think, by the complete uncertainty about what's coming out of Washington too. Because not only do we not know what the future of the Affordable Care Act is, we don't know about children's health insurance, we don't know about what happens after Friday right now. Granted that this will air on Sunday, and maybe we'll all know one way or the other. And so these things are concerning to people in the context of the whole on the issue of health care. And I think that's where a lot of the fears do come from.
And I think that's a good point, especially because you made a career out of understanding insurance. You are a medical doctor. You understand that these issues are all interconnected. But with that in mind, is the executive order connected to the dual waiver proposal that is coming before the legislature soon, or are they independent of each other?
They're independent of each other, but they're all part of the same effort to reduce costs and to provide access to Idahoans and Idaho families. We're all part of the governor's broad vision. This and trying to address residency program and trying to address doctor shortage and buying medical seats, all of those have been features of his administration and are features of what he is pushing forward here today. The dual waiver program is more focused on the gap, the folks that are caught between Medicaid eligibility and subsidy eligibility, which is a basic unfairness. I'd love to talk about how unfair the ACA is in that regard. And then it's also focused on those with significant high-risk, expensive conditions and trying to be compassionate towards them, at the same time trying to help their costs from impacting everybody else.
So walk me through exactly what the dual waiver program would do for Idaho.
So there are two waivers, one that the Department of Health and Welfare would apply for and one that I, as the Director of Insurance, would apply for. The first waiver Health and Welfare would apply for is called an 1115 waiver. It takes certain end-of-life, significant conditions that are very expensive, that have a significant savings if they were covered under Medicaid versus under the private coverage. And yet they would provide better benefits for those individuals that have those horrendous conditions. It takes those conditions and allows those individuals to move over from private coverage over to Medicaid. It's similar, we already have a provision in law that allows a woman with breast and cervical cancer to be able to do that. So this expands it. When you think about it, if we do it for breast and cervical cancer, why not stage 4 metastatic cancer? Why not hemophilia? Why not paraplegia? Why not some of these other horrible diseases and conditions that people have to face? So by moving those individuals over, it saves our state at about $200 million. Now we end up spending that. We spend $100 million on the of total budget with $29 million of state funds, but the total impact to the claims being played out on the individual market is about $200 million. That's a 20% reduction in rates if we can do that. That's a 25% savings to the federal government in premium tax credit. We take that savings to the federal government and we say, we want to use it to help people below 100% of the poverty line be able to obtain coverage. I can't tell you, prior to this, I was an agent and I would sit down with families, and I could sit down with a family of 3, and based on their income, they'd qualify for a subsidy. And then they would tell me, but I'm expecting. So I'd say, okay, let's run the numbers so you'll know what your rates are going to be after you have the child. And all of a sudden, now they don't qualify for a subsidy. There was a cliff. If you made below a certain level based on your family size, you could go from having a subsidy one day to not having a subsidy another day. Or I can't tell you how unfair it was that I'd sit down with a legal non-citizen who is here and obtaining coverage, and they'd get a subsidy. And the same citizen, same family size, same income, would not get a subsidy. So what my waiver does is ask the federal government to allow us to provide a subsidy using the savings from the first waiver, allow us to apply a subsidy to all Idaho citizens from 0% to 400% of poverty.
But once again, that's dependent on the federal government. Any indication that they're going to go along with this plan if it gets through the legislature in the first place?
Well, we've had a number of conversations with them, Department of Health and Welfare and us, And by the way, the governor's been great, and the Department of Health and Welfare have been great working on it, and they've helped us be able to talk to the right people at the right times. The 1115 waiver, there's no pushback on that, and frankly, that portion has been done in other states. Now, no other state has combined the two, and no other state has applied for a 1332 the way we're applying for it, although a number of states are watching and would like to follow us. The 1332 doesn't give them pause at the upper levels of management, but when you get into the weeds a little bit, we're getting some question and some pushback. They see the benefit of it, but we've got our work cut out for us. And we are proposing a piece of legislation. We've introduced it in Representative Wood's committee, and we're trying to solve that. Now, I need to just say real quickly, that is a carefully crafted piece. It's not perfect, and we, in fact, we had a meeting with CSIL the other day, and we'll have to make a little bit of an adjustment in that piece of legislation. And we heard some of the comments that legislators made that we can improve upon a little bit. But we have to be a little bit careful. It's a tightrope walking line, because it doesn't do us any good to pass a piece of legislation that's loaded with things that the federal government won't accept, and then have the legislature leave town and us not be able to get the waivers approved. So we're asking for caution and thoughtfulness as we move that piece forward, and hopefully we'll be able to get that through the legislature. Because if we can't, we're stuck.
And my understanding is that if both waivers aren't approved, then it doesn't hold the program
Right.
up. We need both, correct?
Right. You have to have both in order to obtain the savings. We're using the savings from one for the other, and the federal rules say you have to show cost neutrality. So it's critical. One of the criticisms we heard is, well, if you only get approval of one, what makes us so sure you're not going to just keep going forward with the other, or you won't try some other waiver? So we've got an added sentence that makes it perfectly clear: if it's not accepted by the federal government, we're not going any further till we come back to the legislature again.
And let's talk about the path through the legislature this session. What do you see happening in your committee and in your caucus?
Well, first of all, we introduced the piece of legislation. Obviously, there will be a C1. There's a couple of small additions, apparently, and there may be more.
Can you explain C1 for the viewers?
When you, the way the bill processing works, you start off with a routing slip called an RS, and it has a number, and it gets introduced. Then you suddenly find out that, well, we need to either add something or subtract something, in this case, a couple of small additions. What you do then is you hold that and you develop a new RS. It may be a new RS or it may be a C1, and then you bring it, and then you'll get a new bill number.
So it's like a revised...
It's like a revised bill. Sure. That's exactly what it is, or an amended bill, if you will. The legislature at this point in time, I think everybody's kind of familiar with it, but only at the 100,000 foot level. Right. Most legislators have had a little bit of an update, but not any more than that. So on January the 24th, at the regular scheduled time for the House Health and Welfare Committee, we're going to have a 2-hour informational hearing where Director of Insurance and Director of the Department of Health and Welfare are going to come to the committee with both of their staffs and bring all of the information, including the exact verbiage that was going to be submitted to the federal government, and they will walk us through at a very granular level exactly how this is going to operate. The committee will have more than an hour to ask all of the questions they want, and then there'll be plenty of follow-up time afterwards, where I'm sure that both directors and their staff will make whatever time available is necessary. We've invited the entire legislature. We're going to hold it in the Lincoln Auditorium, and it will be visually and audio streamed so that people can go back and look at it in their leisure develop questions, and then go to Director Cameron's staff and Director Barron's staff and say, hey, walk me through this again or whatever. So I anticipate you'll get a lot more feedback after that, because quite frankly, a lot of people's attention are not focused on this yet. They certainly will be soon, because I anticipate having a hearing on the merits of the piece of legislation probably a week to 10 days after the informational hearing. I'd like to get that done by the end of January if possible. That would give then the Senate time to do whatever and go from there.
And what's the view from the Senate?
Well, I think, first of all, I appreciate the fact that Representative Wood is bringing this early. One of the things we run into here is things kind of popping up toward the end, and they don't get the discussion that they deserve. And I can't represent, obviously, all of the senators in telling you what the view is, but I think that this effort is a very genuine effort. When the ACA was adopted and the subsidies were put in place, it did identify a gap population. Part of the reason that gap population exists is because of those faults within the ACA, but another part of the reason it exists is because we've not opted to expand Medicaid in the state of Idaho. And so we've been trying to get at this problem for quite some time, and over the years a few proposals have come forward, but they've not really been meaty enough, if you will. They've been small amounts of money that weren't directed in a specific area, and I think it is a widespread belief amongst many legislators that this is a meaningful proposal. Does it get at everything? No. Does it, help everyone in the gap? No. But it has some significance and weight to it that I don't think that we've seen in some of the prior proposals. So I do believe that there's a willingness to really engage in this discussion, but also a desire to not let this be the end of the conversation, because there's still going to be folks that are going to be struggling.
And this won't be the end of the conversation on Idaho Reports either. Thank you all three so much for your time.
Betcha.
Thank you.
Thank you.